Alrighty. Good afternoon, everyone. Welcome and thank you for joining us today in our very first discussion, which is about difficult decision series panel series. I'm Neetu. I'm a care services coordinator for the Northern Virginia territory, and I will be your moderator for today. Today's difficult decision panel series will focus specifically on nutrition and ALS. You will learn about diverse perspectives from industry professionals, people living with ALS, and also caregivers and support individuals as they have different conversations around the topic. Now, without further ado, we'll turn the time to Sandy. She is a registered nurse and also an ALS clinic coordinator. She will talk to us today about what is a PEG tube, why is a PEG tube needed, and if you have any questions, you're more than welcome to put them in the chat box, or you can also put them in the Q&A, and we will answer them throughout session. So, Sandy?
All right. Bear with me. I'm just going to let you know I work last night, so going to be a little tired here. But anyways, we are going to be talking about feeding tubes, or PEG tube, which means percutaneous endoscopic gastronomy, which is pretty much a tube that goes from the stomach from the stomach outside to the abdomen, the percutaneous meaning through the skin. And this what allows our nutrition to be given to meet your nutritional and calorie needs when you're unable to swallow. And with ALS, obviously, a lot of the bulbar muscles are affected, be it with swallowing, speaking, and especially with respiratory. So this is where we're kind of getting into that discussion with the feeding tube. When is the best time to get it? And we'll go from there. Normally, a feeding tube is put in via either by interventional radiology or more commonly put in by like a GI doctor through endoscopy. The actual procedure itself, I don't know if anybody's ever had an EGD before, which is a scope that goes down the mouth into the stomach. And then from there, they're able to use that tube. And typically they go through the stomach and they're able to use local anesthetic on the abdomen. They make a little incision and that's where they pop in the tube. Usually done on the same day procedure. You're usually in and out unless there's any complications. Normally for anesthesia that's used, typically twilight or moderate sedations where you don't have to be intubated. There are some cases where I have had some patients that have had to go under general anesthesia. So it kind of depends on the doctor who's doing it, the anesthesiologist involved, and it's best to talk with them to see what would work best for you. So why would you get a feeding tube? For most patients, it's with ALS. You usually have issues with trying to get enough calories, enough nutrition, and enough liquid into you to keep you hydrated. And especially if the very first muscles that are affected are swallowing, if you have a lot of choking episodes, and just you run that risk of having aspiration pneumonia where liquid and food go down the wrong hole. That could be serious as far as leading to pneumonia and could be deadly. So for most of my patients, when I usually talk to them, this is usually one of the first topics I bring up, usually within the first clinic visit or two, even if it's just for them to think about. The sooner a feeding tube is put in, usually the easier it is for the patient, so they're not using up all their energy. Typically, if you're having a lot of weight loss, if majority of your day is consumed with trying to get enough food in or liquid, and you're just spending all your energy throughout the day just worrying about food and water, that could be an issue. If the bulbar muscles are affected, your swallowing ability, the respiratory, will usually broach the topic of feeding tubes sooner. Usually the biggest component for this procedure to get it is usually your forced vital capacity. That pulmonary function test you get to kind of test your lung capacity. We usually don't want to, most anesthesiologist doctors won't touch if your forced vital capacity falls below about 50% of predicted. Now, I've had some GI doctors and anesthesiologists are comfortable with going down as far as 35%. It depends upon the GI doctor themselves or the interventional radiologist and where you go. So it's the sooner you get it, the better chance you have of not having any respiratory complications during the procedure. Sorry. And what are the main advantages I'd say with the feeding tube? One, you're not choking. You don't have any issues as far as chewing, using up the energy that we mentioned. It's an easier way to take in your nutrition. Usually the dietitians will usually recommend some type of formula and X amount of water, be it flushes or free water flushes to meet your hydration needs as well. This is just an example. This is 2-cal-HN. It's a very high calorie dense tube feeding. One of these, if given just at one time, is called a bolus feed. So if you hear me refer to it as a bolus, it's usually just one serving of this at a time. But besides the food, the water, it's also an easier way to administer most of your medication. If there are certain medications that you're on that cannot be crushed, you might want to speak with your doctor and the pharmacist as far as seeing if there's a liquid form available or if there's an alternative that needs to be done. So it allows you to spend less time, less energy worrying about taking in your nutrition, improving your quality of life. Why are some reasons people don't want a feeding tube? One, the procedure itself is a surgical procedure. A lot of people don't want to deal with the discomfort or the pain. I've had other patients just not comfortable with the idea of what they consider artificial nutrition, and they don't wish to go that route. And I respect that. I usually give the rationale, based on where they're at in their progression as well with ALS. If they're bulbar onset, I do encourage it. If they're at the point where they're unable to take care of themselves and rely on a caregiver a lot of patients aren't comfortable with it. So it depends on the situation and the comfortability as far as the patient and caregivers as well. When is the right time to have the feeding tube placed? Usually the sooner the better, just we mentioned before with the respiratory status. And as far as like the actual formulas that you need, the amount of liquid, that's where you speak with your registered dietitian. There's many different types of tube feeding to meet your needs. If you're diabetic, there's like, for example, Glycerina. If there's issues as far as going to the bathroom, there are ones with fiber in it. I've had ones for patients that aren't able to tolerate normal tube feeding. So there's a variety of them out there. And if one doesn't work for you, let your doctor know and your dietitian, and they can always work with you, and you can always try a different tube feeding. Can you still eat with a feeding tube? Speak with your speech therapist, dietitian. Yes, we usually allow our patients oral for pleasure, as we say, as long as it's safe and you're not having any issues as far as choking on it. You're eating the correct modification diet for your swallowing ability. We have no issue with that. And as I mentioned, yes, you can take your medications through it. They can be crushed if they're allowed. Liquid form is usually better. And as far as the teaching, we usually either the clinic will show you with the nurse. Most of the times it's usually home health that will come out and kind of work with you. As far as the administration of tube feeding, there's different methods. As I mentioned before, with the bolus feed, with the can where you give, like, if they say you have like one can 6 times a day, usually administered through the feeding tube with a syringe, provided typically with insurance. When if they pay for the tube feeding, they'll get supplies with it as well. That's your bolus feed. It's syringe, and you'd also use that to give the water or any fluid. There's also gravity bags. This is just one random brand. There's many different brands out there, but you can, if you have an IV pole, you're able to hang it and then attach it to the end of the feeding tube. There are also machines, if you qualify via that for a continuous feed, that will send it in at a certain rate. I'm trying to think. As far as recovery, if you do get a feeding tube, usually you're using it the next day. They'll give you instructions depending upon if you get it through GI, through interventional radiology. You're typically using it within the next day, and they'll walk you through instructions. Usually you want to flush it at least once every, I want to say 24 hours within that first week or so. You're kind of keeping an eye on that incision site where the feeding tube goes from the stomach to the abdomen, keeping an eye out for any infections. Usually it heals up rather well, and the site matures. For some patients that are worried about the look of the feeding tube, if you will, because there will be a tube that sticks out, usually about 6 to 12 inches with a clamp. There is a flatter profile, which is called a Mickey button, typically used for a lot more kids, but it is available, but that also depends upon the specialist that puts it in. I've had GI doctors that usually recommend waiting on the site to mature, so usually about 3 to 6 months. So if that's a concern, or if that's something of interest, ask them when you get to that procedure. And I'm trying to think, I can't think of anything else. Am I missing anything as far as this?
I think you jotted down pretty good in terms of what the PEG tube looks like and when it's needed. My one question will be, how do you start the conversation at clinic with a new patient regarding a feeding tube?
I usually broach the topic of, as far as eating goes, like, are they having any troubles as far as just swallowing? How many choking episodes are they having? Are you having difficulty as far as drinking water? How much energy, how much time is used for you to consume that? Is it so much of a worry for the patient that they're just, that's their whole focus throughout the whole day, where it's, impinging upon their quality of life? From there, and also depending upon where the stage of where the disease is at and which muscles are affected, I will usually mention about a feeding tube as far as helping them conserve that energy, taking a lot less of that worry off of them. Especially with the fluid part, that is pretty daunting when you're sitting there and you're worrying about having to take it in, or for patients that aren't interested in using a thickener, because that can be, I have a lot of patients that are like, nope. And depending upon the brand of it, if you have the more powder form, it doesn't taste that great. The texture, I know for some isn't not favorable. There are other brands out there, liquid, where you don't taste it. You can actually use it in soda. So there are other options out there, but for those patients, I'll mention a feeding tube and whether they have even any interest at all. If I get the absolute no, I don't want it, I'll just mention, the pro side to feeding tube. But if they don't want to, so be it. I'll usually provide information as well with the patient and the caregiver. And that's usually within the first clinic visit or two, just because, as we all know, the pulmonary side can be very fickle. They can change dramatically, but just in a few months from one clinic visit to another. So our main concern is just making sure if you are interested, you get it done in time. Because if you end up going under general anesthesia, if you get intubated and your respiratory muscles are that weak, there's a chance that you might not get off that ventilator.
Thank you so much, Sandy, for that. That was very important and knowledgeable that you shared with us. I'd like to take this time right now to also introduce the families that are participating on the panel today, and then we will start with our Q&A. So we'll first start with Joan.
Hi.
Hey, Joan, and then...
Hi. Hi, everybody.
Hello, Joan.
Hello.
All right, and then we also have AJ with us today.
Good afternoon.
And we have Kay joining us.
Hello.
And we have Randy.
Hello, everyone.
Alrighty. So we'll start looking at the questions. And I see the first one, Joan. After patients have a conversation at clinic regarding feeding tubes, what kind of support do families look to you for?
Well, usually it depends on how long it's been since they have been diagnosed and uh, how close they really are to needing one. If it has been mentioned to them casually at the clinic, some of the people come back and talk about the fact that they're afraid it is being presented as a no-brainer, but to them, it was a very personal thing and a big source of fear. And so we go over what was actually said at the clinic to them to try to explain why it was said in a more casual way, because the surgery is not a big concerning thing, but that it is a personal decision, and they may come to that. What they feel today may be different than what they feel in a couple weeks, or when they actually are having greater difficulty eating, and their decision today is not signed in stone, and that they can change that. And but again, how the clinic brought up the respiratory concerns is a major thing to worry about. And we reinforce the pros. And then another question I get very frequently is, if I decide not to have one, what will happen to me? Will I suffer? And we go over the benefits of hospice at that time, and how a person can be kept comfortable, and that they don't have to spend the rest of their time with this worry. And so those are some of the things we go over. They also are worried about, and this usually comes from some of the caregivers. They will discuss, am I up to the challenge of caring for this? And so we will kind of go over again what was said to them in the clinic, how the procedure is, or not how the procedure is done, but how the day-to-day use of it is done, and that it isn't a frightening thing. And everybody, if they just learn slowly, is capable of doing this. And that even the care of the stoma is not a frightening thing. And so those are some of the things we go over.
Joan, you mentioned a great point where caregivers often think about care management, and I want to hear AJ and Kay, your opinion on this. What was your experience like with care management for your loved ones when they got the PEG tube?
I can start, I guess. For us, I think the most frightening thing was just the decision to get the PEG tube. And to your point, Joan, it's a big deal to us because we're having it done, or our loved ones having it done. But it's a pretty standard procedure for the doctors and the nursing staff. And in the majority of cases, there aren't going to be unforeseen issues as a result of getting it. But I will say that I don't think I was fully prepared for the care of it before my husband got it. So I absolutely would recommend trying to get as much information on how to maintain it prior to getting it. I thought the staff that put it in would give me a lot of information on how to care for it. And I realized that they actually didn't on a day-to-day basis maintain or care for it. They just put them in.
Right.
So I wish I had known to go to a home health care immediately, or to have done a lot more research in advance. Because again, I went in assuming I would get it all, at the hospital after he had it put in. We were fortunate and found a GI nurse in our neighborhood who was retired, and just having her there nearby was a great comfort. The actual maintaining of it really is not that difficult, but you do run into things. You do have to change the feeding tube periodically if you've had it for, I don't know, 6 months to a year. I think sometimes we could go a year. It is pretty simple to change out, but if it comes out, it can come out on its own, usually not the first one. But there are different types that they can put in. And we did have one come out on us, and that was scary because I was like, how do I feed them? How do I, but again, that wasn't a huge deal if I knew what to do about it. So the more you can learn about it and having resources that you can contact are probably the most important. We did find benefits of having the feeding tube. It was a great way for him to release air or gas that sometimes he wasn't able to, have the muscles to do it, like through a burp or whatever. So yeah, it's daunting because you don't know about it, but once you know about it, I would say it gave my husband a good extra 5 years of life because he had it for that long. So I'll let Kay jump in if she has anything.
Well, I had the same experience as AJ did. They don't give enough information and they just suggest and they give you window. You get it. If you don't get it, you pass the window and you have to go to hospital. So at that point, we made a decision. My husband at that point had a nurse, home aide that unfortunately kept showing him all the scariest stuff about feeding tube. My husband did the research and I didn't, not that much. I knew that the feeding tube is going to give him life expansion. And we asked in the office, we asked the people that is he going to continue enjoying eating food? And the person said that absolutely, he can enjoy it. And when he needs the feeding tube, we are just putting it in just for the time that he needs it. And I said, so, and I repeated again, the next day after surgery, can he continue like right now, enjoy the food that he eats regularly? And they said yes. However, in the hospital, right after they put the feeding tube in, the story changed. It was like he was subjected to something that he didn't want to do. And my husband was extremely upset. I was crying and I contacted the professional that they scheduled all these things and they were like, no, your aide said that he aspirated and we have a record and because of that he can if he continue eating he can get pneumonia and they scared us and it took 24 hours for them to change their decision and that was 6 months ago. My husband still eats by mouth. We just flush his feeding tube once a day. I had an episode of infection because my husband has extremely sensitive skin before getting ALS, and now his skin is more sensitive. So even the paper tape gives him problem. Just like AJ, they don't give you enough information. The next day, we got fortunate. The next day that the nurse came to teach me how to use the feeding tube, that nurse from Genesis was so nice. We got lucky because the following week after she left, they sent another nurse that didn't want to deal with feeding tube, didn't want to even check the feeding tube. And we were very upset and we contacted the ALS clinic and we reported that we are still having problem. I'm new in the feeding tube thing and I need more help. So they sent exact same nurse that didn't want to deal with anything. And she watched me how to do the feeding and everything. And she said, you're doing okay, you're fine. And you don't need help. You know what you're doing. So nobody explains anything. Because of his skin sensitivity, I did a research on a computer and I found one of those belts for feeding tube belts that you put the feeding tube inside the belt. I got that. Unfortunately, it pulls on a feeding tube. and it created some sort of infection.
Mm.
So we end up stop using that, and my husband still asking for the bills, and I don't know what to do. He gets irritation because of the tape. Other than that, we don't have any problem yet. I modified his food before he could eat meat. Now he cannot eat meat. So I try to smash the meat or use beans or other source of protein to introduce to his food. Other than that, he's fine for now. We are going day by day. Yes, we have days that he refused eating food, and I contact the ALS clinic before this episode happened, and they told me to put Ensure into the feeding tube, so you will have enough nutrition for him. However, I noticed that they didn't tell me that if you put Ensure in a feeding tube, you have an episode of going to bathroom in 5 minutes. You have a bowel movement right away. So we are trying, and I think the medical professional have to spend more time instead of scaring the patient. They have to spend more time with the patient, see what exactly they want and what they enjoy, instead of changing their decision the day after the surgery. They should see what happens to the patient. One coughing episode is not aspiration. We change his water with the bubbly water, so he still drinks with straw. No, and he doesn't. We are careful. We give him small portion of food. We change even the spoon that we are feeding him with, so it won't be a full amount of food that we are putting in his mouth. And he's fine with it for now. It's been 6 months. And I asked, this is interesting that Sandy brought it up. I asked about the feeding tube. What will happen? Does the feeding tube will come out? And they said no. And right now I heard that after 1 year or 6 months, you might have problem with the feeding tube. So this is something new to me that I just found out, that I have to look into it.
And thank you, Kate, for also bringing awareness to that side. Sandy, we do have a question. How do you determine when it's no longer safe for a patient to eat by mouth?
Typically when you're having usually multiple choking episodes a day, if you've been hospitalized before with aspiration pneumonia, usually those, if you're noticing you're having more weight loss than normal, obviously with ALS, as many patients have found out, the metabolism speeds up. So if there's continued weight loss, even with, not getting enough calories in there, but typically it's usually how many choking episodes you're having, the difficulty of getting any food down, the weight loss, signs of dehydration. That's usually their kind of big key there.
Thank you so much. We've heard a little bit on the care management side. Randy, we have a question for you. What are some things you took into consideration when you were making the decision to get your PEG tube placed?
My primary consideration was being available as a parent to continue to raise my young children and being available to my adult children as a father. Additionally, I also considered my desires to continue to enjoy the activities that I have always enjoyed: movies, music concerts, sporting events, etc.
Thank you, Randy. Just like you mentioned, taking your kids into consideration, were there any changes to your activities of daily living after you got the PEG?
I did not experience any changes to daily activities. I continued to work and attend the extracurricular activities for my younger children.
Thank you, Randy. For caregivers, similarly, were there any changes to your activities or your day-to-day routine that were changed after the PEG tube was placed?
For me, I would say only for the positive, just because we had more time in the day. Previously, it would take a really, really long time for me to cut up and feed my husband, and make sure he was trying to get enough nutrition. After the PEG tube, we actually used the bag that Sandy showed us, hung it, even before we thought to ask for an IV pole, we just hung it, high enough that it would, gravity feed, and he could hang out and do whatever while he was doing that. So we could attach it, to his wheelchair, and he could go places even while he was eating, go for a walk or something. So that part of it was really nice. And I was going to mention that, Sandy made reference to the regular tube that usually extends, out a little bit and can get in the way of things versus the Mickey being a little bit flatter on the stomach. And, my thoughts on that were we kind of went back and forth on which one would be better. By the time my husband got the feeding tube, he didn't have a whole lot of mobility. And as a caregiver, I found the tube to be a little bit easier to access and to put the food in. So I think that might be a consideration when you're trying to decide if you're still able to be physically active, then you might want to consider the lower profile feeding tube. But if you're not able to, jump around and move around a whole lot anyway, I do think it's a little bit easier for the caregiver to have the longer tubing. But yeah, like I said, it was a life improver for my husband. I should have mentioned earlier, and to Kay's point, we were very careful of the skin, around the site, and if there was plastic, touching him from a little tube holding it in place, a little disc holding the tube in place, we just made sure that was always dry and real clean. A lot of times we put a gauze under it, so a little bit more maintenance in terms of making sure that site, stayed clean and infection free. But overall, I'd say it improved our quality of life.
Thank you, AJ. You also mentioned about feeding tube in a mixed. Could you just briefly tell some of families about the difference and which one? Why would someone opt for one?
Are you going to direct that to Sandy since she probably knows more? I wasn't sure.
No. Or, AJ, if you would like to answer, the floor's open to everyone.
I don't know a whole lot about the Mickey, except that, like I think Sandy mentioned, that it's often used for kids, because if a young kid just, they're very active and can't eat, there's a lot less chance of it getting hung up on things or getting in the way. I want to say that when my husband's tube came out, it was a combination of me putting a shirt on him and maybe tugging on it a little bit, but also there's a balloon that you inflate with sterile water to hold it in place once it's inside the stomach. And I think that the integrity of that might have been a little bit compromised as well. So the balloon deflated, and so it came out. So that's the main thing I know about the difference in the two is making sure that whether or not you're worried about getting hung up on things versus the ease of the caregiver. And again, I think Sandy also mentioned this, that back when my husband got his PEG tube, they were asking or saying that you had to get the regular tube first and then later come back and get the Mickey. And we were kind of also like, we don't feel like going back in, for that. But I don't know, Sandy can probably tell you more technical differences. I don't know if there's any difference in the actual placement once you go back in and get it.
Can I add something?
Certainly, Joan.
Okay. A lot of patients that I deal with, families that I deal with, have commented that if they're still very active and they like to travel or things like that, the Mickey did not allow for them to feed in public as easily. They had to expose it, whereas the tube could come out from inside the shirt, and there was less of an inconvenience to the patient. So that's when you talk about changing lifestyle, that is one of the things that I think is a major thing to consider.
Can I ask a question? Sandy, they didn't offer us the different tube. They just put in a tube. And my husband, they said that he's no longer can roll over to the side. Does Mickey allow him to sleep on the side and move more, or is it the same as the long tube?
The Mickey itself, like as far as if you're worried about the tube like catching if he's laying on his side, some patients I've had issues or they've had complaints, like if they use a gait belt to help with mobility, the tube can sometimes get in the way. As far as turning him, there shouldn't be an issue as far as if he had the tube versus a Mickey. The Mickey does allow a flatter profile, but as was mentioned before, it can be pretty inconvenient because in order for feeding to be popped in, you have to have a special kit that comes with your tube feeding, and it kind of snaps into the Mickey button, and then that's how you feed it. That's how you insert or get the nutrition in there, if you will. As far now, like I said, if it's concerned, if the tube, if it's pulling, if that extra plastic exposed to the skin is causing a lot of issues and irritation, and Mickey might be better, just so it's like less concern as far as getting caught, getting pulled. But as far as the tube, no, it shouldn't affect the way that he lays or anything. But I can imagine it's uncomfortable if he is laying with the, on top of the tube, just kind of inserted into the, pushing into the abdomen there. And I guess my other thing I really wanted to mention really fast as far as the feeding tube goes, if you do have that, you notice that little bumper, it's like that little plastic piece that goes up against the abdomen. I've had a lot of patients where it kind of starts getting loose and there's a lot of play room between the bumper and the skin. You don't want that extra play. You kind of want to pinch the tube and push down that bumper so it is flush with the skin. Because if you have all that extra play and the feeding tube is moving around a lot, that can cause issues as far as more infection goes, as far as that maturing site. So if it has a lot more room, it can cause more problems. So you want to make sure that little bumper is flush up against the skin, not super tight, but you just want to make sure it's not free floating either.
How you can make it tighter?
You may kind of pinch, hold the tube, and you should be able to slide it down. Don't force it, just it should be able to slide down the tube a little bit so it's flush against the skin. If there's issues, usually I'd refer back to the GI doctor if there's a GI nurse, but I've done it before just because where I wasn't originally familiar with it as much, and I've had a GI nurse come to clinic and address some feeding tube needs. She did show me that, so it is possible. Hold the tube, just gently push down, but you just don't want that free flow.
Is the gate belt is the safe thing? Because I thought that it's causing the feeding pull on the feeding tube.
That is a concern. I'd still recommend it if needed for transferring, or just be careful with the positioning of the feeding tube. Like I said, I know somebody mentioned the holder before as well. Was it you as far as it pulling too much? I've had some patients go on like Etsy or some other sites. They found some really cute craft ones that kind of help secure it a little better or protect it. But I understand it's a concern as far as the gate belt. I'm not really sure how else to address it, especially if you're a female and your breasts can get in the way, especially with the belt. You just have to be careful as far as positioning and just how it's secured is the best way I can say it.
I have one last question.
Mhm.
We still, when my husband, we take him to take a shower, we still cover the feeding tube with the sticker that protect the water get into the area.
Mm-hmm.
Should we do that, or should we stop doing that?
You should usually, once the skin, if there's no signs or symptoms of infection, you usually can just clean it with soap and water. I would avoid direct water, just hitting it with soap, just kind of, scrub around it. I wouldn't do any lotion or moisturize or anything that could cause some issues. But as far as being in the shower, as long as the site is mature, I don't see an issue. Like I said, if some water got on it. I've had patients that have swam with it before as well, but usually that's, once it's matured and you don't have any issues as far as any drainage or anything from it. But I wouldn't stand there under the shower with water constantly going down on it either, but some water on it's not gonna hurt it. And that's what the GI nurse recommended is she doesn't recommend always using a gauze either. That's usually within the first week or two, unless you do have the issue with the sensitivity with the plastic up against the skin. But usually you just kind of keep it clean with soap and water in general.
Okay, perfect. Thank you.
One other comment that was made that I would like to answer if I could. When you said about putting Ensure in the tube and it will be followed immediately with a bowel movement, is that the way I understood it?
Yes.
Yes. That usually comes from holding when you give a bolus feeding, from holding it too high and it goes in too fast. That will stimulate a bowel movement. You should hold for that first feeding, for most of the feedings, that should be given over like a 20-minute period of time. And then that won't happen.
Oh, okay.
Okay.
See, this is another thing they didn't tell us.
Okay.
Perfect. Thank you.
And just for comfort, that's why we didn't do the bolus feeding with my husband. It was just too much at once. It made him uncomfortable. So I think part of it's just kind of learning what your husband is going to be most comfortable with, or your loved one is going to be most comfortable with in terms of rate at which the food goes in. But I agree, Joan, you can do it way too fast.
Right, exactly.
Thank you, Joan, for bringing.
Good to know.
We do have one question. Someone has asked, are nursing visits post-procedure to teach tube care covered by insurance?
It was for my husband.
Well, from what I've understood from my patients, it is, if it's written as an order by the doctor when they discharge the patient after the procedure is done.
Thank you, Joan. And then our last question, what is something you wish you knew about PEG tubes prior to getting one placed?
I think for me, it was just knowing more about the maintenance of it, and kind of places to go if I had questions about the tube. Again, we encounter probably all of the things that could happen. One of the things, sometimes the feeding tube can get clogged up. And if you can't get water or anything to go in and you're trying to give medicine, it can be a little disconcerting. And we did learn some tricks. It's kind of tricky though, because I think a lot of your medical professionals won't necessarily recommend certain of the things that we used that worked fine for us. I think the standard answer is, if you're, sometimes you can give it a little bit of time. You can kind of, like we used to kind of just rub the tube and stuff and see if maybe it just wasn't kind of backed up a little bit, and try to put a little bit in and maybe wait a little while. If my husband could move around at all, try again a little bit later. But the recommendation that most people give on that one is, to go ahead and, call someone, whether it's a nurse, or take them to the doctor or whatever. But when it's an emergency and you're kind of nervous and trying to get medicine in them, just kind of having a game plan maybe, of knowing the things that could happen and how you're going to respond to it. I don't want to go too much into detail. Some of the things that we actually did, because they aren't necessarily the things that should be recommended. But if you do your own research, and if you are able to get that home health visit, just ask all the questions about, what do you recommend if it gets clogged? What do you recommend if the feeding tube were to come out?
Thank you.
Can I add something?
I wish I knew how to unplug the tube when food gets stuck. This is something that we have experienced with and learned on our own.
Yeah, it seems like most people learn that one on their own.
Can I add something? Can I say something?
Yes, Kay.
I think with ALS, medical profession, they don't spend enough time with the patient. They do their suggestion and move on, and they leave the patient by itself. It shouldn't be our responsibility to go blindly to learn and try to help our loved ones. In other cases, when the patient needs feeding tube, they spend more time. They do a lot of caring, and they do a lot of follow-up. They don't let the patient to be left out with the loved ones. It shouldn't be our responsibility to contact or try to find out what to do or what if. It should, right now, I don't know. I did this procedure at Johns Hopkins, one of the biggest institutions. However, we left out alone. We don't know who to contact. We contact the ALS clinic, and we get some answer here and there. But the medical team that did this procedure, the radiology department of the Johns Hopkins, they didn't even leave us a phone number to call them the night after the same night after the procedure. So all these things is not acceptable as a caregiver and as the patient, which is my husband, is not a wrong thing to do. It's the best thing for the patient to do. If they have the opportunity, I think they should get the recommendation and do it. They should tell the patient that you can still enjoy eating the small stuff that you used to eat, and just watch and be careful. They should send a nutritionist instead of telling us to do research. I feel until last week, I didn't know how much calorie my husband should take. He cannot go out anymore, but we managed to weigh him and be careful with the weight loss and monitor him. The medical field is unfortunately with the ALS, it's not good. They like to do research, and they don't have as much support for the patient. And when it comes to feeding tube, they don't give enough. They give the information, and they don't tell the patient that it will improve your life quality. And if you lose that window, you cannot get the feeding tube.
You raised
Yeah,
some,
Most patients are afraid of getting feeding tube because they think that their life changed.
and you raise a great point with that. We actually have someone who's inquiring about comfort care, what that would look like if someone decides not to get a feeding tube placed.
Can I take that?
Yes, please.
Okay. By that time, if in my support group and then the patients I deal with, and I always try to get them admitted to hospice. And if the person, if I am referring them to one of the hospices, that's a step in being accepted into the process right away. The patient may still look good, they may still be walking, but if they're a bulbar patient and they have chosen not to have a feeding tube, the decision to accept them into the hospice process at that point may look like they're not ready. But that's a point I always make to the hospices. This is a patient who has limited intake of food, and so they are choosing not to have one. So that gets them accepted into the process faster. Then through the course of that, their palliative care, the food is manipulated in different ways. We go from cutting them small pieces to smaller and smaller and smaller until it's even pureed might not be enough. And then it is, ensure by mouth or something like that. And even when that is not possible, then the medication that hospice keeps available at all times for a patient, there's always an emergency kit that is placed in the patient's refrigerator that has all of the needed comfort medications in there to handle that process. And so when no food is able to be ingested, there is usually a combination of morphine and Ativan that the patient is given to keep them comfortable and relaxed. And because of their weakened state at that time, they usually, medications given together are increased periodically depending upon the needs of that specific patient, and they usually slip away comfortably. And that is the important part of having a discussion and ahead of time where the patient is fully informed about both choices. Not that I think that the choice not to have a peg is quite the same, but I think that we don't want people feeling that they're being forced into it because of fear of what life would be without one. So I just think they need that full explanation of what is available for them if they choose not to have one. I always call it the pros and cons. The pros are way up here, the cons are down here, but the cons can be managed. I don't like to hear a patient tell me they were told by a doctor, well, you will starve to death. It's not quite like that. It is managed care where the patient can't stay comfortable.
Thank you, Joan. And I know we're approaching the end very soon, but I just wanted to get this one last question. We have a caregiver who's asking, what is the best way for me to learn how to change out a Mickey key myself for a patient while at home?
I can honestly say I'm not all that familiar with the Mickey, so I'm not sure if they're actually referring to the button itself. That would be something to refer to the GI practice or interventional radiology, whoever did it. I'm not sure on that. If he's referring to the kit that you snap in, that'd be different. But I'm honestly, I'm not that familiar with the Mickey button. I haven't had any patients switch over to that. So unfortunately, I couldn't answer that very well for you. I'm sorry.
Thank you. And then
I would like to say something about the food I use.
yes, Randy.
I wanted to maintain a regular diet of table food. I wanted to keep eating the same foods that I have always eaten. To accomplish this, we used a Nutribullet to blend the food mixed with Gatorade. This was my way of maintaining my intake of the nutrients needed. I tried the supplemental dietary drinks, but my system did not take well to them.
I think that's informative, Randy. I know I wanted to have my husband have the most natural type of food possible. And as Sandy mentioned, there are different types of formula food out there. We were told you have to start with this. And we did, but then within 2 weeks, we're like, he can't tolerate it. So we were able to switch. Hopefully you don't have to start with what they tell you to now, but I agree with you. I think getting the nutrients that you want, you need is another good thing to look into.
Right. So much for sharing that, Andy. I know someone wanted to double check if you mentioned Gatorade. So those are all the questions we have for today. I want to thank you all for your time, for coming here today, talking to us, and the families joining in, and also the families for taking your time to coming in and joining us. We will continue with this panel series. We have another one scheduled for next week, Wednesday, where we will talk about breathing and ALS. Please do feel free to reach out to me if you're interested or if you have any questions. And I hope you guys enjoy the rest of your day. And I want to thank you guys again one more time, and to all our panelists today. You guys have a good one.
Thank you.
Thank you.
Thank you.
Bye.
Thank you.